Next is v10. It's a damage control surgery trauma-laparotomy. So what is damage control surgery trauma-laparotomy? So DCS or damage control surgery complements damage control resuscitation. It is concerned with the restoration of physiological parameters and not anatomical correction. Its purpose is to control the catastrophic hemorrhage and minimize contamination. This is an abbreviated or staged laparotomy where the operation can be rapidly terminated at any time if the patient deteriorates. Laparotomy may involve proximal vascular control of the aorta or feeding vessels, placement of gauze swab packing or compressed bleeding points, temporary control of the contamination by placement of the soft bowel clamps. Concurrent damage control resuscitation involves resuscitation and treatment of acute trauma coagulopathy with packed red blood cells, FFPs, cryoprecipitate, and platelets, and tranexamic acid guided by near patient using thromboelastogram in warm operating theatre. The patient is in essence made fit for operation and no longer in danger of suffering from lethal triad of hypothermia. Why does the trauma triad occur? Why does the trauma triad occur? So it's due to three components: hypothermia, metabolic acidosis, and coagulopathy. So hypothermia, heat loss due to exposure pre and perioperatively, and hypothermia, inability to generate heat loss and inability to generate, and metabolic acidosis, tissue damage, massive transfusion. Metabolic acidosis due to tissue damage, massive transfusion, poor cardiac output, and decreased tissue perfusion, anatosis and peripheral vasoconstriction. And coagulopathy, consumption of clotting factors and other components of coagulation pathway affect hypothermia and acidosis. When do you consider the need for damage control surgery laparotomy, and how can you predict when it will be required? So there are certain indications. Patients whose mechanism of injury suggests they will be suffering severe injury, like falls from heart, multiple penetrating injuries, multi-organ cavity injury, and high injury severe cavity. Any patient presenting with acidosis, pH less than 0.2, hypothermia, temperature 34 degrees centigrade, and coagulopathy measured by thromboelastogram, serum lactate more than 5, and base deficit more than 6, are the patient who deteriorate intraoperatively despite DCS, who have worsening coagulopathy, acidosis, and hypothermia. Patient who are non-responder or transit responder to fluid resuscitation and require ongoing massive transfusion. Possible time-consuming procedures in an unstable patient. Planned resuscitation, reassessment of the abdominal contents, inability to close abdomen due to visceral edema, and to avoid the potential development of abdominal compartment syndrome. How do you perform damage control surgery laparotomy, trauma laparotomy? So early decision making to perform damage control surgery, abbreviated WHO surgery safety checklist, command huddle to discuss the management plan for DC and DCR. This will be followed by 5 to 10 minutes progress update along the Boston mnemonics, blood products, arterial gas, surgery completed, temperature, and equipment required. Patient position in the crucifix position with arms out under patient warmer in a place, catheterized, operating theatre, temperature turned up. Patient prepped from neck to mid thighs to permit access to the chest, abdomen, and pelvis and groin vessel if required. Long middle laparotomy, incision, assistant follows with surgeon around the abdomen with Morris retractor, large gauze swab packing in a sequential manner, starting at most likely point of injury, round the clock, counting swabs in and confirming swab count, and with scrub nurse. Pressing on the packed abdomen and discussing the anesthetist's immediate finding and possible surgical plan. If ongoing arterial bleeding is encountered, then proximal vasculature aortic control needs to be gained to prevent exsanguination. Remove packs from the least injured zone to the site of suspected bleeding, and deal with the possible arteriovenous bleeding before contamination control. So contamination limiting. So stapling bowel ends without definitive repair. Stapling bowel ends without definitive repair. Occlusion with umbilical tape, suture, or towel tag ligation. Bowel anastomosis and diversion delayed until reoperation. And temporary closure, skin only. Contamination limiting, stapling bowel ends, occlusion with umbilical tape, suture, bowel anastomosis, and diversion of delayed until operation, and temporary closure skin, towel clip, sandwich technique, Baguta bag. Precise documentation of the operator finding plans for relook, discussion with the family and relatives, ongoing damage control resuscitation, on ITU, restoration of the physiology, correction of hypothermia, is essential for the enzyme function, especially in the coagulation cascade. Core temperature should be more than 35. So how we can correct it? Passive rewarming by bear hugger, warm fluid, humidified ventilated gases, and active rewarming, lavage of the thoracic and abdominal cavity, and lavage of the gastric and the bladder lavage. Correction of the coagulopathy, aim to achieve INR 1 less than 1.25 and normal thromboelastogram. Optimize oxygen delivery and improve the tissue perfusion to reduce the lactate to less than 2.5. Planned definitive surgery within 24 to 48 hours. Secondary look procedure, underwater removal of the packs, hemostasis, restoration of the GI continuity, stoma, debridement of necrotic tissues, abdominal wall reconstruction if required, composite or vicarial mesh, and component separation or vectrous sheath lateral release. What is evidence for damage control laparotomy? There are no randomized controlled trials that are from the small studies showing reduction in mortality with damage control laparotomy to in multiply injured patients. Prospective study showed mortality lower than the prepossum prediction with DCL. Thank you.